going to discuss cardiac imaging. So before I begin, I'd like to correct myself. I think um, I said a couple of times in the previous presentation that the left clavicle is the left ventricle. So it's clavicle, not ventricle. I'm too lazy to edit the whole thing. Okay, let's now go into cardiac imaging. So cardiac imaging is basically a multi-modality approach. There's no one single imaging modality that is best for everything. So we have to tailor fit the needs of the patient, also the availability in our setting, the prices, of course, and that's why we'll basically be more focused towards chest radiography because it's still the most commonly done study and it's a very good screening tool for cardiac diseases. So here are some of the samples of imaging modalities. Um, Exercise testing and echocardiogram is more of the scope of cardiologists. So this is more sa internal medicine. They look at the ECG and images of the heart muscle function and valves. For nuclear medicine or the gamma cameras, this is another branch of diagnostic imaging. Uh, Nuclear medicine talks or involves diagnostic and therapeutic imaging. So they use radiopharmaceuticals that will light up certain parts of the body to help them diagnose diseases, and it can also be used for treatment. So more on that will be discussed by Dr. Rakamamot after the radiology part of the lectures. No? Then for us, on our part, now the common imaging modalities used are cardiac CT and cardiac MR. Although in our setting, in RCT, it's not yet very commonly done. We have cardiac CT now. I think Polymedic Plaza offers that. I'm not sure with CUNC. Um, it helps us, can look at the cardiac function as well as measure the different anatomic parts of the heart. But then again, this is not part of our scope in discussion. I'm just presenting it to you so that you have an idea that they exist. So this is an example of how imaging is used um, in actual practice. So for example, we are dealing with a thrombus. So in these cases, um, we have to determine what we want to know. So if we're deciding on morphology or sizing, we have two options in this example. We have transesophageal echocardiography, or you can have CT angiogram of the heart. So it depends again on your primary objective and your secondary objective, and it will also help you identify what is the proper imaging modality to use. So for example, if you're looking into pulmonary vein isolation, so you want to determine the pulmonary vein anatomy, geometry, number, as well as exclude thrombus formation, then CTA would be the study of choice. So this is just an example. So each clinical scenario will demand a different imaging approach. So it's good to know what approach we will use so that we can save time, money, and resources. for both the patient and on our part also. So this is another example. So in imaging patients with spontaneous coronary artery dissection, so we have different options. We can look at CTA, can help us identify the true and false lumen. If we use coronary angiography, you'll be able to see these different types. So type 1 could be a contrast staining in the false lumen. Type 2 would show us the diffuse stenosis. So we'll not be able to see the outer lumen or a false lumen. Or it could be type 3. You have features similar to atherosclerosis. So you have multiple filling defects, which can be attributed to your plaque formation from atherosclerosis. Again, it's a multimodality approach. You can also um, ask the help of nuclear medicine to look at the heart and its function. So we go back. So you already know that this is how a normal chest x-ray looks like. We've trained your eyes to look at it as a normal radiograph. And much of our discussion will be focused on chest radiograph. So this is just an annotated image of the chest, and it highlights important anatomic structures that we see. So again, I'll go from top to bottom. So this is the tracheal outline, so we'll see it as a lucency. It will branch out to your main bronchus here around that T4 level. So this is where the carina is. And when we look at the ribs, or this one, the annotated third rib, this is the posterior segment, and this is the anterior segment. We also have to look at the and trace the medial border of the scapula because sometimes it could be mistaken for a intrapulmonary density. Then, in the scope of our topic, we look at the cardiac shadow. So the border forming chambers of the heart are your right atrium, which forms the right border, and the left border is formed by your left ventricle. Then you have your main pulmonary arteries. Your ascending aorta is this area, and your superior vena cava are superimposed in this region also. These are your cardiophrenic angles and costophrenic angles. Again, this is the diaphragm, so you must make sure that the dome is preserved on both sides. And this is a female patient, so you have a breast outline on both sides. So we can appreciate, for example, in cases of patients who had mastectomy, the breast shadow could be absent on one side. So this radiograph, this is a patient in actual practice. What I wanted to highlight in this example is this structure. If you can see, you have two rings. One ring is lucent, one ring is dense. So a more close-up image of that here. So this is the typical anatomy of your pulmonary vessels. So this is the vessel, and it has an accompanying airway. So these structures will go, as they go towards the periphery, they will get smaller and smaller. But the ratio of their sizes, the diameters, should be more or less 1 is to 1. So if the ratio is not 1 is to 1, there could be a problem. So for example, if the vessel is larger than the um, bronchus or bronchi, then you would suspect that the patient has congestion or pulmonary hypertension. So also, if this one is the one that's dilated, then you could you could suspect there would be some sort of air trapping, maybe bronchiectasis, or it could be a nematocele formation. So those things are important. So this is our clue in confirming our diagnosis if we're suspecting congestive changes or any pathology that relates to the caliber of the pulmonary vessels. So in this case, it's normal since the ratio is 1:1. So the pulmonary vasculature is not dilated. So this is just a normal radiograph. Although we have some degenerative changes like your aorta is a little tortuous and you have osteophyte formation along the thoracic spine. Now we go to the lateral view of the radiograph. So sometimes the lateral view is warranted to help us identify pathologies which might be obscured in the frontal view. So in this case, this is your lateral view. So this is the shadow of the heart. This is your retrosternal clear space. So this is the sternum, and this is the retrosternal clear space. So it's a lucent crescent between the sternum and the ascending aorta. So your ascending aorta is here, this density, although it's not so well defined in this case. Your hilar region would be in this area. So you have to look at for discrete masses. Commonly, it could be enlarged pulmonary vessels or enlarged lymph nodes. Then the fissures, they are pencil point thin and they traverse the lateral view diagonally here, around in this area. And the thoracic spine, we look at them one by one to make sure that more or less the configuration is the same for each. And a true lateral radiograph would warrant the ribs would be superimposed to each other. So this is actually slightly oblique, but it's relatively of good quality since we can see very well the thoracic spine and as well as the retrocardiac space. So this is the retrocardiac space. Some vessels will taper off in this area, but usually it's more lucent, relatively lucent. And sometimes it could hide also pneumonia. This is that is hiding behind the heart, and that's commonly seen in the pediatric age group. And also the diaphragmatic dome is again preserved on lateral view. You have to check that the dome is preserved. And posteriorly, you have to make sure that the costophrenic sulci are sharp. So just a little blunting could be due to pleural effusion or thickening. So I'm going back again to the PA view and the important landmarks along the cardiac silhouette. So again, the border forming radio chambers are your right atrium and left ventricle. If your left atrium is enlarged, usually this area would be straightened. Early stage, now we can see a slope. But if it's enlarged, this would be straight. And if it's much more enlarged, it would be convex outward. So that's our clue that there is left atrial enlargement. The double density left atrium can also be seen here in this area. I'll show an example later on. The ascending aorta is expected in this region, but usually again it will hide and superimpose itself to the thoracic spine. That only the aortic knob is really seen when looking at normal radiographs. So you know that if there's some slight deviation of the contour, then you suspect that there is some problem or some degenerative changes as the patient grows older. On CT scan, this is what we see. So the image on your in A, this is an axial view at this level, around this level. So you can see the arch of the aorta. This is a superior vena cava, label S. T is the trachea. So black, it's all black because that's the airways, and you expect them to be loosened on CT scan. And here are your border forming chambers, the right atrium on the right side and the left ventricle on the left side. So this is what we typically see on your chest radiograph. So I just superimposed our previous image of a chest radiograph with the CT scan image I showed just the slide before, so that you have an appreciation of how it looks like, or what is really going on behind the scenes. On lateral, so this is how it appears. This is the ascending aorta that I mentioned earlier that will create your retrosternal clear space in between the sternum and the ascending aorta. And border forming on lateral view is your right ventricle anteriorly. So if your right ventricle is enlarged, you will lose some of this retrosternal clear space. And your left ventricle and left atrium is border forming posteriorly. So if it's enlarged again, it will extend here. We'll discuss later on what sign that is. If your left atrium is also enlarged, it will push itself towards this area.